Today we're going to be talking about hearing loss in the adult population and issues of aging. So this is really going to be focused more on the elderly adult population. I'm going to apologize in advance. I'm doing this recording at home and you may hear my two dogs in the background. Little bit about me. I have two dogs. They were both adopted from the pound and they are full of character, which sometimes is fun and sometimes is not. So if any of you are pet owners, I'm sure you can understand. So let's kind of look at the profile of the adult client. So typically, when we're working with adults, we can see a certain type of hearing loss, and there's definitely an increase in the prevalence of hearing loss with an increase in age, and you can see that easily in figure 10.1 of your text. Part of that is that adults are living longer, and Interestingly, the population over the age of 85 is increasing faster than any other group. So we're living longer and we're seeing how hearing loss can affect these individuals in this age group. Maintaining good communication abilities is essential to maintaining quality of life. And so as they age and as a hearing loss becomes more significant, they may see a decline in their communication abilities, which eventually could lead to a decline in their quality of life, which can also be contributed by a number of other factors. But typically we see a certain type of hearing loss. We call this hearing loss presbycusis, and this is hearing loss related to a decline in hearing associated with aging. By the age of 75, approximately 50% of the general population will have a clinically significant degree of hearing loss. That's a pretty large number. What's interesting is that the average age of the first-time hearing aid user is close to 70 years of age, according to Sergei Kochkin in a study that he completed in 2011. If you're going into the field of audiology, you're going to become very familiar with Sergei Kochkin. He does a lot of research looking at hearing aid use, hearing aid users, satisfaction with hearing aids, all sorts of factors related to oral rehabilitation. And he does these large surveys and collects data from a huge population. So you'll probably see his name mentioned more throughout this semester, and certainly if you continue in any audiology courses or into an audiology program, you will hear a lot about his research. But so he says that the average age of the first-time hearing aid user is close to 70 years of age. This is despite the fact that the majority of people with hearing loss, approximately 65% of the people with hearing loss, are actually below the age of 65, and nearly half of all people with hearing loss are below the age of 55. So I know I've thrown out a lot of different numbers and figures at you. Those aren't necessarily ones that are important to memorize, but just kind of looking at this trend. So remember in previous discussions we've talked about how hearing aid users typically wait, or I should say individuals with hearing loss typically wait a certain number of years before they actually start to pursue any sort of treatment or rehabilitation. And this is definitely evident in his research where, most people are getting hearing loss maybe in their 50s, but they're waiting until their 70s possibly to obtain hearing aids. So that definitely plays into how we approach oral rehabilitation with these adult clients. And it's something that audiologists and clinicians are working towards educating individuals sooner so that we can start the rehabilitation process sooner as well. Some things to consider, why are these individuals waiting so long to seek help? Some of it could be related to either prior experience with other individuals with hearing loss, possibly their parents or friends with hearing loss. If those individuals maybe had a negative encounter or poor satisfaction when using hearing aids, these individuals may be less likely to pursue amplification or rehabilitation. Are these individuals coming to see an audiologist on their own free will, or has it gotten to the point that their communication abilities are affecting not only them, but their communication with family members or friends? And so now those individuals are kind of helping to push them in the right direction and guide them into coming to see an audiologist. So like I said, we're really, as a profession, trying to develop ways to reach this population sooner so that they're not waiting until they're 70 to start using hearing aids. So we were talking about the type of hearing loss, and again, it's often referred to as presbycusis, and this is the decline in hearing associated with aging. And this is an example of a typical audiogram for an individual that shows signs of presbycusis. It's typically a sloping, high-frequency hearing loss. So if we look at this audiogram, remember that the frequency range runs horizontal and then the intensity runs vertically. So with the frequency starting at a lower frequency, so more of a bass tone around 250 hertz, going up to 8,000 hertz, which is more of a higher frequency, higher pitch. And then intensity starts at a very low level and goes down to 120, which is extremely loud. The right ear is the red circle and the left ear is the blue X. And I like this one because it does show some different ranges of hearing loss. So you can see white is the normal range, and then yellow is mild hearing loss, blue moderate, light pink is severe, and a darker pink is the profound hearing loss range. So as those symbols for the right and left ear go further down on the graph, that signifies more hearing loss, and you can see that it's sloping in those higher frequencies. You're definitely going to want to review the audiogram and how to interpret the audiogram if you're still having any questions or concerns before you do the Unit 1 exam. Just a hint while we're talking about that. So with presbyacusis, it's difficult. We can't always say that this hearing loss is only related to aging, only related to the body wearing down as we age. Often it's going to include some other factors that have contributed to the hearing loss. That can include noise exposure, if they've worked in an environment with loud noise, if they were in the military, if they enjoyed recreational activities with noise such as hunting, shooting, power tools. It can include other medical issues, other types of hearing loss, but in general, for most individuals, even if they don't have a significant amount of noise exposure and their overall health has been good, it's normal or more common to see a sloping high-frequency hearing loss. If they have a significant amount of these other factors, like the noise exposure, we maybe would expect to see a more severe amount of hearing loss. It may be affecting more of those lower pitches, mid to lower pitches as well, so it may not be so focused on those higher frequencies. But with each individual, it's going to be different. With the higher frequency hearing loss, that's really going to affect a certain area. It's going to cause challenges communicating in certain situations. And we'll talk about this a little bit more later, but really they're going to be missing out on a lot of the clarity of sound. And so it's very common for them to say, one-on-one, I do good. I don't have that much challenge communicating in a quiet situation, but if there's a group of people or if there's background noise, it makes it a lot harder for me to understand what someone's saying. And that can be a number of factors, but part of that is missing out on some of those higher frequencies where the consonants of speech are contained, and those provide us with the clarity of speech. So with the adult elderly client, not only do we see this drop in their pure tone threshold, so on that graph where we saw it sloping down in those higher frequencies, but there can also be some other issues at play that can also contribute to that difficulty with the clarity of sound or difficulty understanding. One of those issues is what we call phonemic regression. And this is where the word recognition scores that we obtained are worse than expected based on their pure tone thresholds. We talked a little bit about this when we reviewed the audiogram and interpreting the audiogram earlier in the semester, but in this case we're seeing that their ability to understand speech is worse than what we would expect just based on their amount of hearing loss. This can also be interpreted as auditory processing difficulties, and that maybe describes it a little bit easier for us to understand, in that their ability to process the sound is impaired, or it's not the same as it once was. So there can be perceptual confusions and distortions of the phonetic elements of speech, and this often involves damage to the auditory neural pathways. And so not only are we seeing damage in the cochlea, leading to primarily what we see in the pure tone threshold change, so that decline or that sloping loss in the higher frequencies, but we're also seeing that maybe there's some damage in the neural pathways, so that the sound as it's traveling up to be interpreted by the brain is being distorted. I'm going to show you this picture because I think it does a good job of giving you a visual representation of what I'm trying to explain. And so you can see with this picture of Abraham Lincoln that each time it becomes less and less clear. And by the final one, if you saw that picture alone, you probably wouldn't be able to distinguish that it was Abraham Lincoln. Possibly even the second to the last one, you might say, I'm not sure who that is. And so this is kind of a visual representation of what someone with phonemic regression or an auditory processing disorder may, this is an example of how they may hear. So they're losing out on that clarity of the signal. In these cases, amplification alone is not going to necessarily be beneficial, because we can make the sound louder, but it's still being transmitted through that neural pathway, and that's where the distortion is taking place. So no matter how loud you make it, that distortion is still going to be there. And so in these cases, there's some other considerations that we need to include when developing our oral rehabilitation program. And so that's part of the assessment process in doing the audiometrics, doing the testing, that we really look at their speech audiometry results so that we can see, okay, are they able to perform where we would expect, or is there the possibility that the neural pathway is being affected as well? Along with hearing loss in the elderly, we also see some other age-related concerns that can contribute or cause further concern along with the hearing loss. So there can be dual sensory impairment. Typically when we refer to this is describing, in our case, visual and hearing loss. So vision and hearing loss. This is very common in the elderly adult population. 20% of those over the age of 70 years have both hearing and vision issues. If you think about this, having vision issues reduces their ability to use visual cues that can be helpful during communication. So without even thinking about it, so many of us, even with normal hearing, rely on visual cues to help interpret when maybe we're not able to hear as well. If it's a poor listening situation, if there's a restaurant with a lot of noise, you may rely on those visual cues to kind of fill in some of the gaps. If you have vision loss, then you're missing out on that ability to help fill in some of the gaps, and so you have a dual sensory impairment. There can also be other physical and mental health concerns. Dementia and depression are common in the elderly population. The prevalence of dementia and depression both increase with age. And there's been a lot of research done looking at both dementia and depression as it relates to hearing loss. And the research has suggested that there may be a correlation between hearing loss and dementia or depression. If you think about it, if someone has hearing loss that's going untreated, then they're having a breakdown in communication, or they're having difficulty communicating, so they may start to withdraw. They may have activity limitations, participation restrictions. They may not be as social, and this can lead to either depression, or it may appear as dementia. And so they're not keeping their brains active, and physically they may not be as active because they're reducing some of their activities and participations. And in this case, really a lot of research is focusing again on that, what I will call early intervention, which usually we use that term for children, but I'm going to use that term here for adults as well, because the earlier we can intervene in these cases, hopefully will lead to less restrictions in terms of activities or things that they're participating in. And so increasing one's ability to communicate better is hopefully going to keep them more active, which will help them stay active physically, mentally, and may delay some of the effects of aging as it relates to dementia and depression. There was a study done that looked at individuals that were diagnosed with dementia, and after they reassessed some individuals that were fit with amplification, a third of those were recategorized into a milder category of dementia. And so oftentimes someone may be diagnosed with a certain amount of dementia, but if there's an untreated or undiagnosed hearing loss, that may be exacerbating their symptoms of what appears to be dementia. So that's also an area where we're trying to promote education, not only of patients, but also of other professionals. And so helping them know, hey, if you've got a client that you're assessing for dementia, let's also rule out hearing loss as a factor. There's also personal and environmental factors. So looking at what resources and support are available to our elderly patients. This often changes as they age, and there's a great table in your book. It's a gray box that goes over, it lists 8 of these different personal and environmental factors, and things that typically change as an individual ages. Some of these include limited financial resources, changes in family, so there may be deaths in the family or new family members added, retirement, so that can change their involvement. It can also change their finances. And although most individuals go through many of these changes, the way in which they react and adapt is very individualized. And so being aware that they may be going through some of these changes, but then also understanding that the way in which they're handling them may be very different from person to person, and that's something that can be included in sort of that assessment process of the rehabilitation model. So looking into some of these a little deeper, if they have limited financial resources, then they may be limited in the type of amplification that they can purchase or use. If they have limited mobility physically, and or also meaning they don't have a lot of family close by, or their spouse may no longer be with them, or they may be a widow, it may be hard for them to get to appointments. They may have to rely on others to get to appointments, which can be challenging. If they live alone, they may have limited communication, and so that may also play into the fact of why they wait so long to get hearing aids. They may not really notice the difficulty initially if they're not having to communicate very often. This also brings to light the issue of being able to hear alarms or doorbells or the telephone if they're living alone. This can be a safety issue. If they do have a hearing loss and they don't have appropriate amplification, they may not be hearing some of these things. And there are certain devices, hearing assistive technology systems, that can help with the alarms. We're going to talk about those later in this semester. So if they can't afford hearing aids or don't want hearing aids, there are still some other devices that you can get to help make it a safer environment for them. And then another more of a personal factor, and this has to deal with a little bit of a younger group maybe than we had previously been talking about, but the baby boomers. And they've been labeled as a sandwich generation because they're typically involved with taking care of their parents, but also still in the process of taking care of their children. So they're taking care of really two sets, their parents that are elderly, and then their children who maybe are still in school or in college. And so they have their own personal and environmental factors that play into all of this as well. When we think about the AR considerations for the elderly adult client, as we've discussed already, there's some specific things that we need to consider in both the assessment and the management of these patients. And we'll also talk a little bit about some of the different ways that we can use outcome measures to assess how the AR process is going. So again, just a little refresher. CORE is that assessment piece of the AR model, and CARE is the management piece. And we're not going to look at this too in depth right now, but kind of a quick overview. The assessment process typically involves the pure tone testing, speech audiometry, because like we already discussed, that's going to be important in helping us know if there's any sort of phonemic regression or auditory processing difficulties. And then also a lot of those self-report tools. Those self-report tools are going to be helpful in the assessment process and in the outcome measures. So they can be useful in two areas. It's kind of like a 2-for-1. You can look at some examples of some of those self-reports. And then with the management, the care, that's going to look at a couple specific areas. A lot of it will be focused on more of the counseling aspect. And this may include creating treatment goals based on their audibility, activities, and participation. The audibility may include amplification, could also include some of those hearing assistive technology systems for more of a safety factor. But some of that counseling is going to be just more informational. It's going to be based on providing hearing instrument orientation, especially if this is a first-time hearing aid user in their 70s. You're going to have to spend a fair amount of time helping them to feel comfortable with how the device works, how to use it, how to change the battery, how to keep it clean, how to insert the device, how to remove the device. If they don't feel comfortable with it, the chances of them using it on a regular basis are pretty slim. If they aren't able to insert it correctly, they're not getting the appropriate amount of amplification. There's more of a chance that they may lose it. If they're not able to take care of it, keep it clean, change the battery, then again, it's not going to be providing the amplification that they need. They may not be satisfied, and it may be just because that hearing aid is plugged with wax, so it's really not working, and they don't realize that's the cause, and they just think, well, this isn't helping at all. Why am I going to wear it? So you have to spend a fair amount of time helping them to gain that confidence. I'm sure you've worked with or have known individuals maybe that are a little up there in age, and some are very savvy with technology, or they're excited to learn about new things, whereas some are more reserved and they may not be as willing, or they may be more anxious or nervous about having to learn about a new piece of technology. And so you're going to have to change your approach based on how they approach the technology. You're also going to be helping them as they take control of their communication activity. And a lot of times this includes giving them some of the resources to create the best listening environment. So I think I've said it before and I'll say it again, the hearing aids are not going to take them back to normal hearing. And there's a lot of things that they can do just on their own to help provide a better listening situation. So that can be making sure that they're facing the person that's talking to them so they have those visual cues, or moving away from a source of background noise. So if they're trying to talk to someone and the dishwasher is running, moving into the next room where it's a little quieter, or turning down the TV if their spouse is trying to ask them a question. So there's a lot of things that they can do, and then there's a lot of things that their spouse, significant other, family members, friends can do. And sometimes it's almost harder to teach those individuals some of these tips, such as, don't try to talk to them when you're in the kitchen and they're in the office, which is 2 rooms down at a far distance. So you're giving strategies to both the individual with the hearing loss and then the people that they're communicating with, so that they can control the situation and reduce background noise, reduce things that may make it more difficult to communicate. There's 2 handouts that we give at our clinic at ISU, and they're called Speech and Clear, and they go through those different tips that I just talked about and some others as well. So I would really advise that you read through those, and you may even find that, hey, these are things I can use when working with individuals with hearing loss or family members with hearing loss. And then also, part of our management is going to be helping them to increase their participation or to reduce those participation restrictions, because again, remember, we want to keep them active so that way we can decrease the chances of depression and dementia and help them to have a higher quality of life. And so a lot of how we decide, what participation restrictions they have is based on their self-reports. And so that's a great way to determine where do they feel restricted and where can we focus our AR goals so that we can reduce those restrictions and help them to participate more actively. And then with the outcome measures, anything that we're doing in terms of rehabilitation, we want to be able to measure, was this helpful? Was this successful? And like I said, this kind of goes along with the assessment piece of CORE in that those self-reports, if you do those pre and post, so if you do them prior to any sort of rehabilitation and then either during or post-rehabilitation, you can compare those scores and determine, did that individual notice a change? Did they notice less difficulty communicating in certain situations? Did they feel like they were more actively participating in some of the areas where they maybe had limited their participation previously? At the ISU clinic, we typically use the SAC and SOAK, but there's a lot of others out there, and it kind of depends on what information you're wanting to obtain and how in depth you want to be. But any sort of outcome measure really should include 3 things: benefit, use, and satisfaction. So is the device or the rehabilitation process, is that providing benefit to the client? Is it useful? And are they satisfied? And this process can be something, like I said, that happens pre and post. It can happen in the middle of therapy. So it can provide feedback and be a continual cycle of assessment and treatment. So maybe you do a self-report tool at the beginning and then partway through, and then at that time, partway through, you decide, oh, well, we've seen improvement in this area, but now they're actually noticing more challenges in this area. So you may adjust some of your goals, and that may change the rehabilitation for the next step. So it's something that's part of the cycle, and it'll also be very individual based on that client. So this chapter goes over a lot of information, and we've really kind of focused on the initial part of the chapter, but it also includes information on a review of where oral rehabilitation for the adult client can take place. This can include a university setting, military facilities like a VA clinic or hospital, community centers, medical clinics, or private practices. It also includes some information on counseling and the psychosocial considerations as they relate specifically to the adult population. It talks about creating and developing communication goals. It talks about the coping behaviors of adults with hearing loss, the amplification considerations, and then also looks at the individual and group rehabilitation strategies. So there's a lot of information in this chapter, and we touched on quite a bit of it now, but a lot of this is going to come into play throughout the remaining part of the semester, and we'll discuss further as we explore some of these specific areas. So I wanted to keep this week's presentation a little bit shorter because you're gearing up and getting ready for the Unit 1 exam. And so I wanted to give you a little bit of information about that as well. There will be a study guide posted, so I would highly recommend that you review that. It's not all-inclusive, but it's designed to help you kind of focus on some of the primary areas that will be tested. If you have any questions after completing the study guide or reviewing it, please feel free to contact me. I would be more than happy to help clarify. But again, I want you to have looked at the study guide, tried to complete it on your own, or focused on those general areas. But if you have specific questions, please let me know. And the exam may consist of true-false, multiple choice, matching. You may be asked to label a diagram or interpret an audiogram, and there may be some short answer. If you have prepared adequately, and that includes listening to each of these lectures, which I know is not always fun to sit through, reading the text, that's a big one, completing those quizzes each week and those extra assignments. If you've prepared by doing those things, then you should have plenty of time for the test. You are allowed to use your textbook, your notes, but do not use any sort of human resource, meaning don't work with any classmates. This is a test that you will complete on your own. And if you are thinking that you'll just look up each answer as you go, then you're probably not going to finish the test in time, so don't make that your strategy. And just be prepared ahead of time. That is my main recommendation. Part of that being prepared is knowing where stuff is in your textbook and your notes. So hopefully you've been able to keep things organized as we go. Again, if you have questions, please let me know with my email and or give me a call on my office phone or post in that I need clarifications forum.